Ma'am, over to you.
Thank you, Shriya, and thank you everyone for joining us. As she mentioned, thank you for letting us prepone the session just for today because of the World Cancer Day event. And we request every one of you to participate in that event at 5:30. The link has been shared in the group. And today, as Shriya mentioned, we have a slightly different topic. We were talking about a lot of medical issues till now, except from the communication, all were related to symptom management, physical symptom management. So today we'll be talking about the psychosocial issues that we see in palliative care and how do we go about in managing the psychosocial issues. We have been talking about these issues, I think, from the day one patients, what all patients can go through. But today we'll hear about it in detail. Today we have Shriya. Shriya is heading the resource mobilization department in Palliative India. So she is more involved in fundraising and building partnerships and new initiatives, but her background is in counseling psychology, and she has done her healthcare management from IIM also. And so Shriya has a lot of different background and work experience other than from palliative care. And I am so glad that we have you with us today. Thank you, Shriya, for agreeing to be part of this program, and welcome you.
Am I audible?
Yes, very clear.
Thank you so much, Dr. Shri Devi and Shri Priya, for such a kind introduction. I would like to welcome everyone today. It's an important day, it's World Cancer Day. And please, just a reminder to join the session at 5:30 as well. First of all, thank you. It's an honor to be taking a session for doctors, and coming from a non-clinical background, it's a bigger honor for me. And please be patient. If there are some things that you don't understand, please feel free to use the chat option. We'll try to make the session as interactive as possible. And there are various points where we'll be having some discussions as well. So thank you. And if I'm going too fast, please do share your feedback and let me know. I can slow down as well. So just sharing my screen. Can you all see my screen? Okay. As I am a counseling psychologist and I've done healthcare management, but also I've been working with Palliative India and the field of palliative care for the last 2.5 years now. And the topic psychosocial aspects was something which is very close to me, probably because I'm not a doctor, so I couldn't understand much of the physical things, but this topic is definitely more interesting and for me, and I hope it interests you too, because there's a lot that we don't explore in medical sciences, mainly the psychosocial aspect. We leave it for the others like psychologists and social workers and others to look at it. But again, I'm sure you've been through how important it is, the importance of interdisciplinary team. So it all in palliative care, the importance of team is very, very crucial. So I'm going to begin my session. You've been through this definition a lot of times, I'm sure, in terms of what is palliative care. And the WHO calls it an approach that improves the quality of life of patients and their families and facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, which could either be physical, psychosocial, and spiritual. One of the things that we miss out here is we write life-threatening, but we don't write life-limiting, which also should be a part of this. And one of the things that we're going to now focus in this is mainly the impeccable assessment that we need to do in treatment of pain and other problems, and mainly looking at the psychosocial and the spiritual aspect of it. So what is total pain? Something that you will keep talking about during all your sessions in palliative care. Physical pain is reported by patient, which is compounded by his or her current life circumstances. So I'm going to give you a very trivial example, which could happen to you, me, anybody. I have a terrible, terrible migraine headache. I get up in the morning. I don't feel like going to work. I call up my boss. My boss shouts at me saying, no, no, you got to come to work. There's so much to be done. I get up, I see the kitchen's dirty. I see there's nothing to eat. I haven't even had my cup of coffee. I head out. I realize the car is not starting. Somehow I managed to get on the way. There's traffic. By the time I reach work, if you ask me what my score at the pain scale would be, I would definitely say like a 7.5 to 8. Um, and this is, I'm just talking about a migraine headache, right? But on the other hand, if I get up one morning, I inform my boss, and the boss is like, yeah, sure, you can work from home. You can take up your tasks, and if you were not unable to do it, it's okay. You can complete it tomorrow. So I'm like very excited. I get a nice hot cup of tea. I can take my time to start my work. Like the day goes on well, and I'm feeling much better. So if you ask me, then probably I'll just say, okay, it's around 3.5. So you can see, even though this is a trivial example, and it's something that is relatable to everyone. And if you see that pain was just not the migraine, it was a lot of what happened in the day that caused it to be, my pain scale to come up. So one of the things that we look at psychosocial aspects is also the social diagnosis, an understanding of a psychological, biological, and social and environmental factors that's operating on the person in his situation. So because we will be, you are going through palliative care, you would be dealing with patients and families who are going through life-threatening or life-limiting illnesses. You can see there are various factors that affect their lives, not just the physical factors. Like I'd mentioned, illness related suffering is so much more than just physical distress. In most of the topics that you would have covered till now, whether it's anything to do with pain management or the symptom managements, would be looking at the physical. But total pain is it's a combination of psychological, socioeconomic, and spiritual as well. So this entire thing can cause total pain in a person. Why is psychosocial care important in palliative care? Like again, living with a life-limiting or life-threatening illness and awareness of approaching death causes unique stresses and challenges. This is not just for the patient, because no man is an island. It also relates to your people around you, your caregivers, your family members, your loved ones, your friends. Everyone's affected by it. A serious illness also disrupts individuals' thoughts and feelings, relationships, and other social and spiritual supports that could be either financial stability and spirituality. Krishna Priya, you've raised your hand. Do you have a question? Okay, I'm going to move ahead. So what is assessment? It's an exploration process of gathering information about the person. It's also a selection of goals and interventions that depends largely on what is being assessed. So why is it crucial to do a thorough assessment? We do in your practices that you do a thorough assessment of the person's physical well-being, but in terms of in palliative care, you also look at various aspects, not just about the patient, about their family, about their surroundings, the environment, everything. And this is throughout the illness trajectory, these stressors may change. So it's important to assess the patient again throughout. And especially if you see in terms of any psychiatric illness, one of the things that they do is generally do a thorough assessment with the patient and the family involved. It's similar in palliative care as well, where we look at a thorough assessment. One of the aims of the assessment is to identify problems areas which result from the illness and may influence the well-being of the patients and their families. Assessment also involves collecting information, identifying and honoring strengths, resources, and needs. Um, Also, one of the just a little crucial thing to remember is it's during the first sitting, a person may not be able to reveal all information to you. You need to build a rapport with the patient and their family. And this doesn't have to be done by the doctor. It could be done by the social worker, the medical social worker, the team, or the psychologist, counselor. Anyone in your team could do this assessment and discuss it with you. Uh, like I mentioned, the first thing is build rapport. I think that's very, very crucial. That's where you are able to collect relevant information and honest information, which will help you which will also help you in planning the goal of care along with your team for the family, patient and the family. Assessment is an ongoing process. Like I mentioned, things may be different in the beginning of an illness, and towards the end of life, things may change for everyone and the patient and the family as well. And the needs of the people change over the course of the illness. And this is done through purposeful observations and purposeful conversations. Like I mentioned, the goal of patient care is important, and counseling and various things, like collecting information, the assessment is like science. It just cannot be done through random conversations. There needs to be some goal setting. There needs to be insightful conversations for you to receive this kind of information. One of the sources where can you get this information is obviously from the patient, but there are times when the patient is very ill. The second person to ask is the primary caregiver. The primary caregiver could be anyone. It could be their spouse, it could be their parents, it could be anyone. And also other sources are friends, relatives, neighbors. One of the things that's important and which makes it easier for the work that even Pallium does is our crucial work is home visit. We visit most of our patients at home, even though many of them get registered with us in the medical college OPD or other OPDs, but we continue meeting them at their home. And if you can see on the left side is a way to a person's house who has a spinal cord injury and is on a wheelchair. And we wouldn't have found out this information if we were sitting in the clinic, and how the person is able to access the home, the way to their home. And on the right side, you could see the condition of living of one of the patients who was going through a life-threatening illness. The roof is missing. And as you know, in Kerala, there's heavy rain. So you can imagine this plight of the family we would have never known or understood if we hadn't visited them at home. So some of the sources of information is important. It's not possible for the clinician or the doctor to visit homes, but you could have your teams visit. It could be a nurse, it could be anyone in your team visit their homes of the patient. And it's important in palliative care to do home visits as well. We're just going to go through a case study, which we'll come back to later. Um, it's a case study about a 33-year-old lady. Let's call her Mrs. A, who's been diagnosed with CA rectum in 2014. She had chemotherapy and radiation followed by colostomy. She was referred for pain management, and at the time of registration, she was presented with severe pain, infection, and a foul smell from the colostomy site. She looked very anxious and scared and had no idea about palliative care. From the medical records and present disease progression, the team had an impression of a very bad prognosis. She's a widow, and her sons are 11 and 8 years old, respectively. So let's remember Mrs. A's story. So we're going to come back to her life again and discuss. So what are the important aspects to be assessed from the point of view of total pain? This is really crucial. These are some of the things I will go through each of them in detail. That we go through is the first is being the patient overview. Second is the insight. Third is family overview. Insight is mainly the insight about the diagnosis, prognosis, and about palliative care. What do they know? And why are they here? family overviews, getting information about illness in the family, which is also collected for general medical records, but also knowing what people do in the family, where the families come from, who's the decision maker, the socio-economic overview. Will the family be able to afford medicines, or would they be able to afford procuring food or rations and other things? Psychological overview, what is the patient and family going through at the moment, and all this needs to be done again and again to assess the patient over time. Also, the spiritual overview, this is something that we generally don't look at in healthcare, but it's also important to look at the spiritual aspect. Psychosexual overview, again, uh, talking about sex is a taboo, so it makes it very hard, challenging for clinicians to talk about this. So this is also very important, and I'll come to that. And also, we need to come up with interventions and plans to help the patient and the family. Uh, what do we do in patient overview? Yes, we collect the basic demographic details. It could be, obviously, it could be where they live, how they're, what is the area, is what panchayat does it fall under, which district, what was their occupation before and after the illness. Many people lose their jobs or are unable to work post any sort of a life-limiting or a life-threatening illness. And also, who's the primary caregiver and what's their relationship with their primary caregiver? Like I mentioned, it could be anyone. There are many times a mother, an elderly mother could be taking care of her young son who may be diagnosed with cancer. You have spouses, you have young spouses taking care of each other at times of illness. It's sometimes children taking care of their parents. So there are various types of caregivers and the relations. In terms of insight of what they know about their diagnosis, prognosis, and what do they know about palliative care and why they sent. And this is not just done for the patient, it's also asked for the family. And this is crucial because this also helps you in terms of how you're going to communicate with the patient. And this will also be covered in your communications class as well. In family overview, most of you know what genograms are. We look at the genogram. You'll also be going through something called the eco map. There are family dynamics. What are the support systems? History of illness in the family, which is also crucial because you know how many times the family has been burdened by a disease. And it also kind of lets you know on how they have been working through it through years. Let's come to the genogram. It is a graphical presentation of a person's family over at least 3 generations, which tells us about structure, dynamics, strengths, and resources. So one of the times, like people think the genogram should only consist of the immediate family. It's ideal to get information, yes, for 3 generations, which could be grandparents, children, the people. It tells you a lot about the family. And the type of information that you need to portray in the genogram should be the name, age, educational, occupational profile, and the emotional relationship. This is an example of, if you can see, this is Mrs. A, the case study we talked about. This is her life. If you see Mrs. A is here, we'll go into the details of the genogram, but you could see a circle is for a woman or a female, and then a square is for a man. And you can see she has 2 children, 2 sons. Across Mr. A's, that means he's deceased. She has a good relationship with her parents, but these red lines denote that she doesn't have a good relationship with her in-laws. And she also had a tenuous relationship with her husband. You could see these dotted lines. And this also talks about what their other siblings and others are doing. To learn the genogram, it's very easy. There's lots of information that's available. There are a lot of YouTube videos. People have different depictions, but some of these are signs which are kind of used universally of male and female. If you're married, if you're separated, if you're divorced, if it's an adopted child, there are various legends that can be used to define the structures of the family. And it also lets you know a lot, give you a lot of insight into the details about the family and the relationship. I'm not sure whether this is clear, but these are some of the emotional relationships legends. And why is this important? Why do you want to know if someone is violent or someone is abusive, someone is hostile, or whether they're in love or they're close? It's actually crucial because most of the times, as healthcare professionals, we seek information from the decision maker of the family. And sometimes the decision maker could be someone who is, let's say, living abroad, is providing financial stability to the family, and they may be the decision makers. But if they are, let's say, hostile towards the family, would you really want to ask them for decisions to do with the family? So it's important to know who the decision makers are, what kind of relationships they have with them, what is the relationship between the spouses, between the children, between the in-laws. All this is very, very crucial. And it also helps through the plan of care on how you should move ahead with the family and look at their pain, especially in the psychological point of view. This is another example of another case where you can see there is a hostile relationship between F and D, the father, oh, sorry, yeah. And there is, the parents are deceased, but the mother-in-law is still alive, but there's still, there is a tenuous relationship, and they have one children. So these are the legends, which actually makes it easier for us to understand. It could be as simple looking as this, makes it very, very easy to have a graphical representation, because if you have a story layout, it's very hard for people to read, and many people are may be overburdened with going through various medical records, information. This graphical representation makes it very easy to understand a family. So now let's talk about the EcoMap. EcoMap is something which a lot of people don't use. Genograms are commonly used. It's a pictorial representation of a family and its social environment and their relationship with the larger society. It's also a snapshot view of important interactions of patient family with other systems like groups, extended families, individuals, organizations, associations, etc. So if you could see, it's important for us as a family, if a patient comes, to look at how their relationship is with their neighbors, their workplace. It could be their current or ex-workplace. Also government services. When I say government services, could be anything on how, if they are receiving any sort of pensions, plans, schemes, local services, their panchayat or the gram panchayat, and these kind of things. Religious institutions also play a very important role when we get to know how what their faith is and what they believe in, and how important religious institutions are in their lives. Friends, also any clubs or other societies that they work with, uh, schools, especially for children, and also family. By family, I mean extended family, and also the healthcare services. How has their relationship been with their uh, current plan of the healthcare service that they're going to, and currently if they are visiting you and receiving palliative care? It's also important to know how it's going for them. Any doubts so far? Please put your questions in the chat box. Let's look at this EcoMap. Okay, this is a American example, but it will be easy to understand. You can see Adam and Louis are a couple in terms of they have Michelle and Greg as their kids. Greg is a little boy, and you can see, let's go. In terms of if there's a straight line, it's generally a positive relationship. If it's this dotted line, it's a tenuous relationship. It's stressful when it's a zigzag line. And the arrows talk about the energy flow. And the line thickness also depicts the intensity of the relationship. Now, if we are talking about Adam and Louis as a family, you can see the church has a great relationship with Louis, but has a very stressful relationship with Adam, and also has a great relationship with Greg. Greg, as the little boy, is has good friends, is interested in computer games. The school has a little stressful relationship with Greg. But however, the counselor in the school has a good relationship with Greg. In terms of Michelle, you can see she's interested in sports. She's also got a scholarship. Let's talk about Adam. Adam has great relationship with his work, but however, he has great relationship with his buddies. He likes hunting, fishing, drinking, playing poker, but you can see this doesn't go too well with Luis. So even this kind of a depiction talks a lot about Adam and Luis and their family. And why do we need to do this? So it actually helps in finding, mobilizing resources for the family. For example, if it has to do with if Louise falls ill and she needs a lot of money for her treatment, we can contact the church and see if they'd be able to help in some way. If Greg is facing issues, we can contact the counselor and check if the counselor can help, talk to the friends. In terms of Adam, for Adam, if he approaches the church, it may not be a good idea, but we can talk about his workplace or talk to his buddies to see if there's any way we can help. So it's important to see, especially for mobilizing resources for the family and connecting them to the right places. It's important to have an eco map. In the socio-economic overview, it's very crucial to check whether the family has at simple, like we say, the basic needs, roti, kapda, makan, basic, do they have adequate food, clothing and shelter is basic, but we need to know, because if you're going to be giving all these medicines to the patient, and if they don't have enough food to take it with, and you say don't eat it on an empty stomach, and they end up eating it on an empty stomach, it's definitely it's really not fair, and it's something to even consider. Who's the breadwinner of the family, who controls the finances is crucial, because many times when the breadwinner of the family is affected, the family may lose its finances, and that also takes them uh, takes them through a really hard time. And as we know, a lot of times healthcare expenditure can cause financial disability in the family, and can change the course of their lives as well. What are the various sources of income that they have? Especially in Kerala, there are a lot of schemes that are there. People receive, there is a scheme for cancer patients, widows, people with disabilities, disability schemes, where people are given a certain small income to get through. But also to see if they are receiving these kind of sources, it's important to connect them to the right platforms where they are able to retrieve these schemes. What kind of debts do they have? A lot of people sell lands, sell jewelry, take money from the money lender, borrow money from friends and family. So you need to know what kind of debts. If a family is in heavy debt, it would be very, very impossible, very difficult for them to manage their lives and uh, go through the treatment. Or sometimes people stop treatment because of having debts. Also, what kind of social support do they have? Like, again, I'd mentioned government schemes, local financial support. What about the education of the children? Does it continue or not? Because most of the times when a disease hits a family, one of the first things that get affected is the education of the child. Sometimes it's stopped, or the child is put into a school which is maybe doesn't have a great facility, and the fees is very low. So these are the things that we need to look at. Let's talk about the possible social impacts. One of the things is social isolation. Still, in many places in India, diseases like cancer are considered a taboo. Sometimes a family gets isolated. People still talk about if you have a disability or things, maybe if you're suffering through cancer, that you may have done something in your past life to get this. So a lot of times people socially isolate families as well. Um, Dependency, if a patient, for example, is going through a spinal cord injury, their dependency, even for mobility or getting through the toilet, to even turning sides, to be transferred from a wheelchair to the bed, to have a bath, to even if they're wearing a catheter, changing, taking out the urine, cleaning the pan, all those things, your dependency on others really increases. And financial instability. Just want to mention that around millions of people are pushed under the poverty line in India because of healthcare expenditure. Uh, a disease can cause a lot of financial instability in the family. Also, lack of social support when they do not have any social structure helping them, that makes it harder. And like I mentioned, a lot of them go through deaths and also loss of work. Uh, these are the possible social impacts that could the patient and the family could be facing. What are the psychological overview and what are the possible psychological impacts? Obviously, there is a lot that a person can be going through. Is first feelings of shock, uncertainty, and hopelessness. When people are diagnosed with a life-threatening illness, or they see, one of the first things that they feel is shock, uncertainty, and hopeless. Not just the patient, also their families, caregivers, their children, everyone. And sometimes people don't see a way forward. One of the things is anticipatory grief. Anticipatory grief is when you anticipate anything bad's going to happen to you, right? So today I was the breadwinner of the family. From tomorrow, I know I've, let's say, met with an accident, have a spinal cord injury. I'm going to be thinking about how am I going to manage the finances? Who's going to take care of my wife? Who's going to take care of my children? Or the other way around, who's going to take care of my husband? What's going to happen? My family, my parents. So there is a lot of time we anticipate what's the worst possible outcome that's going to happen to us when we are diagnosed. And also poor insight. A lot of times, the diagnosis and prognosis is not of the disease is not conveyed or communicated properly with the patient and the family. So they may not know. A lot of times people come thinking if they may be terminally ill and they still have hope. It's okay to have hope, but no one has told them that what's going to happen in the future, how what their prognosis is going to be. And many people are not even aware why they are sent for palliative care. So it's important to convey information to the patient and the family. And poor insight can actually make the family make a lot of poor decisions as well. Anxiety, very something that I think many people went through even through the pandemic. It's crucial. You can see a lot of ads on social media now. Are you anxious? Are you going through anxiety? Seek psychological help. Anxiety is something that is uh, I would say it's also like it's a part of the pandemic now. And we don't know what's going to happen when the next lockdown would be, what's going to be third wave, fourth wave, fifth wave. All those things that are happening around us has made a lot of us as human beings very anxious. Suicidal ideation or wanting to hasten death. It's a lot of people may not fear death, but they fear the process of how they would die. If they see themselves, if they have a terminal illness, a lot of people fear that they would, uh, you know, um, uh, as in it's, they would fear the, that how the process, would they be suffering? Would there be any other issues that they would be seeing? And just wanted to inform, there was a study done by the Economic Times when they saw that 1 in 5 suicides in India are committed by people living with advanced or chronic and life-limiting conditions. So you can see suicide ideation and people with life-limiting or life-threatening illness is high, and it's also important for us to address it. And it could be caused due to anticipatory grief, insight, anxiety, various things. And wanting to hasten death, they think just relieving them of the suffering is putting them to, for them to face death as soon as possible. Also, poor coping with the illness, which is very, very common. And it's, as healthcare professionals, it is our duty to ensure that the patient and the family cope well with the illness, and also giving them all insight into their diagnosis, clearly communicating with them through their prognosis throughout the illness trajectory. That's important. And psychosocial and spiritual suffering is real, but can be very difficult to recognize and treat. And this can also manifest as physical complaints. And uh, and like I mentioned again, these assessments, we need to build rapports first. And rapport building is so crucial, and ensuring that you're there for them. And that's when people feel comfortable and open up more. And so you can have a more thorough assessment and provide the family with a better plan of care. So, what is spirituality? A lot of people mistake um, a person's uh, faith or religion with spirituality, which spirituality is a person's connectedness to things and their meaning in life. For me, my connectedness to nature is something which is very spiritual for me, or maybe with animals and various things. So everyone has a different insight into spirituality. Um, some of the four areas that we can look at are connection, meaning and joy, strength and comfort, and hopes and concerns. Uh, this is it can some simple questions, but they may have very, very deep answers. In terms of connections, you can check who are the persons or communities you look to for support. What role do they have in your care? Do you have an image of power greater than yourself? Has your life situation now affected your feelings about yourself, your faith, or your relationship? These questions can be changed as per the based on the how the cultural and the social scenario is. Also, assessing their meaning and joy. What has been the most important in your life? What are you most thankful for? What makes or has made you happy? What made you feel the proudest in your life? Looking at strength and comfort. Is there anything that is comforting to you now? What helped you get through difficult times in the past? And what is your source of strength at the moment? And hopes and concerns. Is there anything that you hope for? Is there anything that feels unfinished? These questions are simple, but like I mentioned, you get some really, really deep answers, and you get to know a lot about the person, what they're going through. And again, these in various ways, through helping the person out through the psychosocial assessment, you would be able to come up with a lot of solutions, possible solutions, which will help the family. In terms of psychosexual assessment, these are some of the things that we do, especially with patients with spinal cord injury, which looks at their interest and their relationship quality. Do you understand the importance of sex? Do you face any desire for change for sex in your life? Do you have an erection, ejaculation? Does your partner feel satisfied with sexual activity? I know these questions are hard to ask as professionals, but we need to get comfortable. First, ask ourselves these questions, and so that makes it easier. Uh, you as doctors don't need to do it, but you could have the psychologist or the counselor or a medical social worker in your team assess. And this will give you a lot of insight into the other things, and also will help with various, if they are facing any physical problems and also any psychosocial issues because of this. Have you noticed any change in sexual relationships, improving sexual functions, and your desire for marriage? You want a divorce, a relationship? How is your relationship? We have a few patients in our care who are young people. There was one case where one of the patients who had a spinal cord injury was recently married. Uh, and the first thing, what happened was the spouse ended up being a caregiver. And there were a lot of issues that they faced as a couple. And so it gets to, and through that, we were able to address a lot of these issues and help them out. They received couple counseling, also talking about what is possible for a person with spinal cord injury, and improving their quality of life in general by just discussing these issues. If you go back to Mrs. A's case, along these assessments that we have done, you can see in physical, she had physical pain, discomfort due to the colostomy bag. She was facing fatigue, body image issue. There was lack of sleep. In terms of psychological, Mrs. A had anxiety about the future, anxiety about her children. She was unclear about her prognosis and palliative care, and also had suicidal ideation, isolation and stigmatized from the family, and was going through a lot of grief. You can see in terms of the socioeconomic status, she had a strained relationship with the husband's family. She also lost her job. She had financial instability, huge debts, house rent, treatment and education of her children were affected. And also the accessibility to the regional cancer center was really far. Also, looking at the spiritual aspect, she would feel why she going through all this suffering. She lost faith in God, loss of connection with her families and friends and community, loss of interest in pleasurable activities, and loss of hope about life. Now, if this is a question for all the participants here, we'll only look at the psychological and the socio-economic aspect now. First, let's begin with psychological. Please enter your answers in the chat box. How do you think psychologically we can help Mrs. A? Yes. If someone could.
Give responses in the chat.
How do you think as healthcare professionals we can help Mrs. A psychologically? Any answers?
Nothing so far in the chat. Anyone wants to psychological counseling, open discussion, arrange someone to sponsor kids' education?
Yes, psychological counseling is very important. Also having an open discussion with her, correct? Dr. Meenu, you had mentioned arrange someone to sponsor her kids' education. Yes, that would be looking at the socio-economic aspect. The physical pain, yes, we know would be taken care by the palliative care physician or you as a physician, but we're just talking about the psychological and the socio-economic aspect. Yes, currently psychological, yes, there needs to be an open discussion, there needs to be a plan of care, and also help the family out with counseling. Yeah. And also, how do you think if you don't have a counselor in your team, what would you do? If there's no one to provide psychological counseling, how do you go about it? Okay. So basically, yes, we will refer. Thank you, Femi. Best ways communication is done. Talking to them and empathizing with them. Thank you, Dr. Arpita. In terms of the socioeconomic area to it, how do we help her with financial instability, huge debts, house rent, loss of job? These three things. Dr. Meenu had said that we could get education support for her children, so this will help her here. But in terms of these loss of job, financial instability, huge debts and house rent, how do you think we can help the family? Any suggestions? Yes, social security schemes. Thank you, Dr. Arpita. It can be looked into. Anything else? Yes, you could do crowdfunding. This is very important. You could raise funds from platforms like Milap and Keto and others. Arrange some jobs she can take in a house, like craft making. Very, very interesting. Yes, vocational rehabilitation. Thank you, Dr. Minu. Can she move in with her parents? Yes, that's also a possibility that can be explored. But they would be elderly, and but however, there would be some comfort as well. Thank you. So let's move on and see what was. Oh, sorry, just going back. Yeah. So if you see the eco map here, this is Mrs. A's eco map. You can see she has, because her husband had died, she's also going through a lot of grief. So you can see she has a good connection with the church. So what could have be explored was mainly supporting her through any of the church welfare activities on how they can support her or the family. She, the local primary health center also had a good relationship. We also were able to mobilize them to visit and provide care for Mrs. A. The RCC, the Regional Cancer Center, was also helping her out with. What we did was, because where she lived was quite geographically isolated, and you could see she had accessibility problems on reaching the cancer center. We had to mobilize some local volunteers in the community. The power of community is very strong here. So you need to look for some people who can visit the family, also try to help them, provide any sort of basic care. If the community can help pitch in for a ration that can help the family, or dropping in medicines so she doesn't have to go out and buy them all the time, or just following up with the family and ensuring that people are there. So we were able to mobilize some local volunteers to do this. Also, she did receive help from Palliative India in terms of her physical and psychosocial assessment was done with the medical social worker. We visited her home to see how things are going. In terms of the school, we were able to mobilize education support through one of the few local volunteers. We wrote the story about her. We didn't mention the name, but we sent out a story to some of our donors and asking them if they were willing to support the education of the children. And a lot of people came forward to support the education. One of the things that we noticed was she had a hostile relationship with the neighbors, and that also kind of, already she was living in a geographically isolated area, and her only neighbors weren't really getting along well with her. We were also able to support her with the children with the peer group, which helped them. Also, there was a weak, the husband had a weak relationship with the panchayat, but we were able to get the panchayat out, and the regional cancer center as well. So you can see there are so many possible outcomes and possible sources that can help the family, and that's how we were able to mobilize resources and help the family out and support them through their issues. Some of the other psychosocial interventions that are possible are family meetings. Very, very important is getting the family together, planning, talking about the diagnosis, prognosis, plan of care with the family, where everyone is required, the decision maker. Maybe sometimes people do involve children, but whatever is comfortable, in terms of also providing them with supportive counseling, have the counselor or refer them, which is crucial. And there are lots of helplines now also across India that you can call for free. Started, there are government initiatives, there are private helplines, there's an enhanced helpline. Even though they may not be physically able to go to a counselor, even a phone call to a counseling session would help them out. CBT-based communication. This is cognitive behavioral therapy, which is it's mainly looking at it from the psychological point of view. Facilitating psycho educational support groups. This is also important on how you can uh, mobilize. Mrs. A was also introduced to a peer group, which is a cancer survivor group, where she spoke to others like her and was able to deal with and find out a lot of solutions to her problems. Bereavement support group and services is important. So we have a bereavement support group that meets once a month. And now currently, because of the pandemic, they've been meeting virtually, where we have around 80 regular participants who come in, who may have lost their loved one a few years ago, but many people to continue to come and support others in terms of their bereavement needs and providing them support for their grief. If you could see, Mrs. A was in a lot of grief because her husband had passed away, and she felt sort of abandoned and alone. So bereavement support is very crucial. Even having the team check up on you, if someone, if the patient is towards the end of life, call up the caregiver a few days later, check on how they're doing, uh, call the children or anyone to check how the family is doing, how if they need any sort of help, and those kind of things. So we, most of our team members do attend funerals of the patients and their families. It's crucial to be a part of it through their entire journey, not just through when they're caring for the patients, but even when the patient dies. Recommendation for government schemes and other financial assistance. Yes, that's very, very true. There are schemes that are there currently. Many state government schemes are there. But one of the other things that we noticed is if you see, one of our participants has suggested that as well, looking for some crowdfunding initiatives that can be done at an individual level. There are lots of cases now. If you open Milab, Keto, even on your social media channels, you have stories about children, people diagnosed with various illnesses, severe head injury to other various issues, various autoimmune diseases, where people are asking for financial assistance. And there have been many, many times people have donated and helped people out in terms various. There was a case in Kerala where a kid had muscular dystrophy, and they raised many crores, even though the child died. But there are times where there are various people come out to help, and these kind of crowdfunding agencies also help you say your story well, and they put out videos. They have videos where the parents are talking about the children. So many things that come up, which actually may help people, may donate 100 rupees to 1,000 rupees. It really, really helps out. And this is something that can be done by you, me, anyone. Linking with community resources is crucial. A lot of times, some of the things like vocational training and all, it would be impossible for you being healthcare professionals to do it, but you can link them to maybe other NGOs in your community who are doing it. Because what tends to happen in terms of palliative care, a lot of patients are at home or bedridden or homebound, and their caregivers end up like stop going to work because they have to caregive. So you could have a vocation that's done at home. Various initiatives are there. You could there's things that you could do, even from terms of pickle making to rearing goats to rearing chickens. There are so many things that can be done, making bags. However, mobilize them, connect them to local NGOs. They can help. Also, these creating, helping them work with any sort of like programs in the community that would help them in terms of their vocation, and regularly following up with the family and the patient as well. Very crucial. Just maybe a call once or twice a month will just to check on them really makes a lot of difference. This is a question for all of you. What are we've all, the last 2 years, we've all been through the pandemic, and you being healthcare professionals have been in the front line. What do you think are the major psychosocial issues faced? Let's start with healthcare workers during this pandemic. If people can come up with some answers in the chat box, it would be great. What are the psychosocial issues faced by healthcare workers during this pandemic? It could be doctors, nurses, anyone on the front line. Yes, you could, I write your answers in the facing death daily, yes, which is very, very hard. Any other psychosocial issues? Isolation from family and community, yes. A lot of times, many healthcare providers had to isolate themselves, were unable to see their families, insecurity, ostracized by the neighbors. There were so many cases where people were asked to vacate their flats and apartments as healthcare workers. Physical exhaustion, yes, correct. Fatigue, criticism, yes, stress, cause of extended work hours. Anything else? Inadequate resources, correct, yes. Emotional trauma. Depression, uncertainty of situations, correct. Thank you everyone these responses. Fear of disease and death, yeah. Fear of spreading the disease to your family members and affecting everyone. That was also very, it's a common feeling now. Can we move on to what are the psychosocial issues faced by family members who have lost a loved one during the pandemic through COVID? What are the various psychosocial issues people faced when their loved one was affected by COVID and was hospitalized and died due to COVID? If you can come up with some emotional trauma, yes. Anything else? Unexpected death, correct, sudden. Many couldn't take part in their last rites, yes, very, very common. I would say not common, but it was a common thing that happened across, that a lot of people weren't able to see their loved ones during their last breath. Take part, yes. Post-traumatic stress, very true. Guilt for not being around, guilt for not being able to be next to them, inability to cope with the sudden loss of a dear one, not able to bid a proper goodbye. Yeah. Many people only saw them online. Yes, virtual. Yeah. And weren't physically around with them, which was very hard for many people who lost their loved ones. A lot of people didn't get closure as well because they never really saw the bodies of their loved ones, and a lot of people, because they didn't see the entire last few moments of their life, a lot of people had didn't get that closure and are maybe they were so guilty and were going through such deep grief. So you can see even till now, people who may have lost someone during that second wave a few months ago are still going through young deaths, leaving behind young widows and children. Yes, a lot of children in India lost their parents, they became orphans. It was, yeah, so many. Let's talk about people from lower socioeconomic status. what are the psychosocial issues that they faced during the pandemic? Loss of jobs, yes. Mainly loss of jobs, migration. I'm sure all of you remember that scene across India where people were walking back home. They were displaced. Mainly financial was the main issue. Yeah, no food to eat as well. Correct. Couldn't come to hospital due to lack of transportation and money. Guilty about not being given treatment. Correct. Lack of healthcare services. Yes, thank you, Dr. Arpita. What are any other suggestions? Yeah, financial burden, unemployment, poverty. Millions of people were unemployed in the last 2 years. Um, People lost their financial stability. People were left, many people's savings got exhausted. There were so many issues that happened. No help from neighbors. Yeah, a lot of people, especially during the first and the second wave, if you remember, if you had COVID, uh, people were just like, uh, buildings were like locking up people and ensuring they don't step out. You were being completely ostracized. uh, can you tell me, we've talked about all the psychosocial issues, but what were the things, how were people, how did people help at these times? How did they support either healthcare workers or people who lost a loved one? How did they receive help during this pandemic and are still receiving help? If people could come up, if you could just write your answers in the chat box. As okay, let's talk first as healthcare workers. How did you receive? Okay, through communication, yes. Financial help. A lot of people provided financial help. Yeah. Also through donations. Yes, a lot of people donated money. Emotional support, calling loved ones, meeting on Zoom. A lot of people distributed food packets. Yeah. Treatment over phone. Yes, a lot of us moved to telemedicine and telehealth and telecounseling. A lot of things moved to. Yeah. What else? What are the other ways? You could see a lot of people collecting money to help families. There were a lot of requests on social media. A lot of organizations got together. There is something called the COVID Action Collab, where people were, organizations got together to help. People were providing free medicine, yes, correct, shelter and food. And also a lot of organizations were also providing a lot of spiritual support. Yeah, people would call in the ICU and for their relatives and provide comfort if they weren't able to see. A lot of healthcare providers, mobilized that for many of the people who were isolated in ICUs at that time, uh, for the families to spend some time even virtually with them. Yeah, vaccination support. Yeah, a lot of people. Yes, sometimes you're right, Sanjana. Social media can increase loneliness and isolation amongst groups. Uh, but there were a lot of channels where it did provide help to people also during the hard times when they were isolated at home or isolated in healthcare facilities. Any other ways people came out to provide psychosocial support? So I just wanted to bring up this topic of the pandemic because it's something that we all can associate with, and all of us have been there. And I'm uh, uh, you were all on the front line, and it's definitely impacted a lot of people. The need for mental health support has increased. You can see, they're going to say after the COVID pandemic, it is going to be a mental health pandemic. A lot of people still going through grief. One of the things that started was various grief support groups had also started, where people had lost loved ones and they meet once a month or twice a month, to talk about them and, work with their grief. Lots of psychologists, counselors, things came into now the kind of the ads you see for mental health are significant. It's almost like it's become a marketplace for mental health. You can see there are so many organizations where you can sign up for a counselor if you have anxiety, if you have depression, get counseling for 500 rupees to 1,000. And, there's so many things that have come up. So moving on, uh, why why do we have to talk about dignity when we are coming to talk about psychosocial aspects? It's very crucial. Dignity means different things to everybody. Um, it also the inability to acknowledge personhood, the insensitivity of not acknowledging personhood can be psychologically devastating. This is There is a beautiful book called Dignity Therapy, which was written by Dr. Harvey Max Choknov, who's for years done research on dignity and what it means and how it can help. In terms of my dignity could be my independence. That's dignity for me, but for someone else it would mean something else. So yeah, it could mean different things to everyone. And one of the various ways of dignity conserving care is also attitude, behavior, compassion, and dialogue. Um, One of the things is just wanted to say one example which could have happened to some of you also. Like I said, dignity to everyone, it has a different meaning, similar to spirituality. There was an incident which happened in a medical college where the medical students were being shown how to put a catheter or something for an elderly person. And the sheet was opened up in front of them and they forgot to cover the person. But and the person's so-called dignity was impacted through this. So there are times we don't see it. It doesn't matter if you are from upper socioeconomic status, lower, all these things don't matter. Everyone has some sense of dignity. And as healthcare professionals, we need to be mindful of these things. There are, like I mentioned, um, caregivers are 4 kinds of people in the world. We're all those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. It's a very, very impactful sentence. And we're all going to be caregivers to someone, or we may require it in the future. So respect those individuals, acknowledge their complex role, never dehumanize them by calling them a bystander. We ensure that we don't call them bystanders. We have a lovely lady who stays in our office. She's also a trustee at Palliative now, where in her 3 years of treatment, not a single healthcare professional asked her mother, who was her primary caregiver, who was with her for the 3 years they spent in a healthcare facility. They never asked her her name. So there are times we need to even ensure that we provide that kind of respect and dignity to the person who is caring for the patient. So just to be mindful of these little things. Very, very impactful question. You can try this. You can try this with some of your patients as well, on how to maybe see what dignity or whatever life means to them is. What do I need to know about you to help you better? Um, there was a case where a person said, my father abandoned me when I was young. So You can see they may be scared of abandonment of some sort, and they have faced it in the past, or they may feel they may be abandoned in terms of receiving healthcare. So we need to ensure we provide them and make them feel comfortable and give them that sense of security that they would not be abandoned. And also, someone could say as something as simple as like, I love going out to eat ice cream, and that this person likes simple pleasures in life. And towards the end of life and stuff, these things really matter on what you need to know about the person to help them better. Just try this question. It's very simple. Try it with your patients, or maybe to begin with, start with your family members, and to see what kind of answers you get. Some of the other helpful questions could be, in terms of your illness experience, how do you define your dignity? If you see, remember Mrs. A's example, because she had the colostomy bag and that colostomy side, she felt she didn't look attractive anymore, and like this entire thing, she was feeling very embarrassed, and that experience could have affected her dignity as well. What supports your sense of dignity? Do you believe that dignity is something that you hold within you, or is something that can be given and taken away by others? These are some of the crucial helpful questions that you can ask. This you can see is a patient who was towards his end of life. So we have an advanced wedding anniversary cake for them, with the patient and the caregiver. Even though the patient was, these little gestures make a lot of impact, especially when people are towards their end of life. Providing them with this gesture, it hardly takes much to do, but it can really impact their lives. And I'm sure the caregiver carried these memories with her and is still carrying them. So some patients' dignity is maintained if something of their essence will survive beyond the event itself. You can see legacy is very, very important. A lot of people write, you've heard a lot of people writing wills. That's mainly from the legal perspective, like, about their properties and the money they have and the properties they have. But a lot of people want to leave something else behind. Legacy just does not mean your money or anything like that. It could be memories for someone. So, for example, and this happened during the pandemic, when people were in ICUs and on ventilators and stuff. A lot of people were asked to leave videos for their family or did calls. So maybe someone wants to leave a small message for the family when they're not around, or people left letters. So many different things on how you can leave your legacy, and it's important to address this with your patients and their families, especially towards the end of life. And through COVID, we were able to see a lot of what are the things they feel which are most important to them, and what they would want their loved ones to remember. Very crucial, and just need to be mindful of these things when you're talking about this with your patients and their families. And it leaves a deep impact then for them, and it's something that they'll remember forever. And you could have your team members do this with them as well. Like I mentioned, all these interventions cover various things. We retrieve information, we try to liaison either with facilities, with the services around them, also provide any sort of facilitation. If they require any sort of rehabilitation, people gave ideas about vocational rehabilitation, providing rehabilitation for the children, providing bereavement support group, follow-up, counseling, psychoeducation. All these are crucial aspects when you are providing any sort of psychosocial intervention for the family and the caregiver. Some of the examples are, you can see goat rearing. The caregiver was home, but she was able to take care of goats. This person's making paper pens. This is a person with a spinal cord injury who makes umbrellas at home, a stitching unit. There are various ideas that are there. There are lots of NGOs who are working towards these things, towards these schemes, and helping patients, people, anyone. and you could probably refer them to that, or have the social worker talk to them to provide some sort of facility for the families, so they're not deprived financially. Support for children, educational and emotional, very crucial, because a lot of times the children are the invisible patients. You don't generally, we don't take decisions. We think they won't understand, but it's they understand a lot. So it's important. And um, in India, one of the easiest things to raise funds, and coming from a fundraising background, is for education support. People, um, even organizations, love to support education because they can see it grow with time, and they feel that they are investing in the seed that will grow into a flower or a tree. So they feel they are investing in something. It's one of the easiest things, and there are a lot of NGOs, organizations, international too, who support educational things. So we need to ensure that none of our patients or children are affected, and yeah, and get them support emotionally. The various helplines now, even if you don't have the facility in your hospital or your clinic, you can always refer them. Always remember to evaluate our interventions. We need to see something may work for people at that moment, but maybe a few months down the line, it may not work for them. So we need to keep evaluating, redo the assessments as well. And we need to also assess how the patient families are being benefited. A lot of times we provide one-time support and we don't see the outcomes of it. There were times where during any sort of a disaster or things, people were just provided blankets or maybe food at that one time, and then later on they didn't have homes to go back to. So a lot of times we have the eagerness to provide support, but it's important for us to assess it over long term as well. And it needs to be revised and updated based on the situation. Good documentation is invaluable because we need to document everything, whether it's notes from the other than confidential information, which would remain with the counselor itself. But anything which is, when you do this psychological intervention, or sorry, psychosocial intervention, you need to ensure everything is documented with their medical records. So next time, even if the person in that team leaves, you have access to the information. If you want to go through the records, see what the patient was going through, you should be able to retrieve all the information in one go. Wherever possible, try to use research validated techniques. There are lots of tools available now, which is accessible for all. And there is an art and science in psychosocial care, just as in medicine. And try to mobilize as many available resources as possible. It's crucial. You never know. Sometimes just a phone call helps people out. And what ways we can mobilize resources? There's a huge pool of resources that are available. I'm just not talking for money. There's also human beings, various other things that can help the patients and the families. And before I end the session, just wanted to talk about, just wanted to share this by Cicely Saunders. You matter because you are you. You matter to the last moment of your life, and you will do all. And we can not only to help you die peacefully, but we will but also to live until you die. So thank you, everyone. I'm going to stop sharing now.
Thank you, Shriya, for that wonderful session. Sorry, I could not inform Shriya. We thought we won't be having a case presentation today, but I think Dr. Ishwar, initially he thought he won't be able to join, but he has joined. I know that, is it okay to have a quick case presentation and take some of the questions together in the end?
Yeah, sure. Sorry, I took so much time because I thought there was no case
No problem. Because initially we thought there won't be any case presentation, so we had time till 4:30. But then I think Dr. Ishwar is available, so we'll quickly go through the presentation and then take up a few questions together.
Good afternoon. Thank you, Palliative India, for case presentation. And today I'm going to case present 54-year-old male, diagnosed case of carcinoma of left buccal mucosa with extensive skin infiltration, fistula formation, and very locally advanced disease, stage 4B. Next. He was present. He was presenting complaint for foul smelling pus discharge from lesions since 2 years and difficulty in initiation of sleep due to intense pain since 1.5 years. Inability to eat or drink anything due to very extensive ulceration over left face since 1.5 years. Worthlessness and helplessness, hopelessness since 3 months. Fear and intrusive thinking since 3 months. Next. History of illness. Patient was apparently well 2 years back when he developed an ulcer on left buccal mucosa. Patient never paid attention to the disease and reported to our hospital 3 months back with extensive disease as mentioned in previous slide. After presenting was taken 40-year history of tobacco chewing and an extensive examination was done followed by proper workup after which chemotherapy with Jeftanib 250 mg OD was started for 30 days, and as patient general condition was not conductive for systemic chemotherapy and any radiation therapy, and palliative care was given with tablet morphine 10 mg QID as IV morphine was not available at the time in our institute. Only oral morphine is available, and aseptic dressing was done or extensive nature of disease. Patient was counseled by the me and our team, and poor GC was explained as provision of proper psychological counseling is not available in our hospital. Next. Examination, general examination, no icterus, no pellar cyanosis, and no clubbing, but facial edema is present on our all over the face. Systemic examination, no findings are done, and local examination, large 7 into 8 centimeter size ulcer proliferative growth present over left buccal mucosa with involvement of gingivobuccal sulcus and gingivoalveolar sulcus, and extended to left reticular trigone and angle of mouth. This is extension into face and with fistula formation and skin infiltration with punctate bleeding and profuse foul smelling discharge from the lesion. Maggot are also infestation seen in this at the disease side. Next. Treatment and significant investigation. Chemotherapy with tablet Gefitinib 250 mg OD for 30 days followed by reassessment of disease extent, palliative care with frequent aseptic dressing, and tablet morphine 10 mg QID and tablet Dalcolix to tablet HS daily for 30 days. Oral medication given via Riles tube, supportive care on admission with total TPN, antibiotic analysis, and oral cavity care with chlorhexidine mouthwash, candid mouth pen for 4 hourly. Investigation, CBC LFT routine investigation was normal, and USG in chest X-ray was and USG bilateral neck shows multiple enlargement bilateral cervical lymphadenopathy, and CCT neck multiple enlarged bilateral cervical lymphadenopathy of varying size with necrotic central core and reactive surrounding inflammation. Next. Psychosocial aspect. Patient is daily wage labor, a sole breadwinner of his family, which consists of his wife and 4 children, which include 3 daughters, all of whom are unmarried, and one son who is 7 years old. He has not been able to work in field or fulfill his daily personal task due to the nature of disease, which have caused him to fall into the pit of depression. His extended family and close friend have abandoned him because of his lesion was profuse smelling, and he is treated like a social outcast. He stay in a 2-room house and stay on the floor of 1 room isolated because of the smell. He does not receive any affection from the children because they prefer to keep away from him. His children tell him our fathers look like monster and smell very bad. Next, medication chemotherapy with tablet Jeftinate 200 mg OD for 30 days, followed by reassessment of disease extent, palliative care and aseptic dressing and tablet morphine and alcoholus also given. Oral medication, all oral medication given by rice tube and supportive care uh, and nutrition, antibiotic coverage, and also oral cavity care with chlorhexidine mouthwash and candid mouthwash 4 hourly. Next. Uh, our main concern, hopelessness and helplessness pertaining to the disease of nature, extreme pain and extensive lesion causing difficulty in eating and drinking, social stigma and ostracization due to intense bad smell and his appearance, and financial problem, psychological problem and stress associated with lack of affection from his own children, and fear of three unmarried daughter. Next. Some be 54-year-old old patient suffering from carcinoma buccal mucosa with extensive skin infiltration and very locally advanced disease. Next. Discussion point. Self-efficacy, how can we enhance self-efficacy and coping with cancer patient? What is effective, and how can we alleviate the pain in this patient, and communicating with patient and caregiver, psychological counseling only for patient or for the close family as well. Thank you.
Thank you, Dr. Ishwar.
Thank you.
As we are running behind time, behind schedule, I'll quickly see some chats from others.
Ji.
And for today's discussion, we'll stick on to the fourth point: how to deal with the isolation, helplessness, hopelessness, and how to talk to family and get support for the patient from the family members if possible. So, what do others think? How to start the conversation and where to start dealing with this? Yes. If Dr. Sanjana is mentioning, if the pain control is not adequate, we can give fourth hourly morphine. I understand it is given sixth hourly, and can add tablets like amitriptyline.
Okay.
I'm so sorry, Shriya, because of the lot of medical languages all through the presentation, but I wanted to end up in this. The last points were typically on the psychosocial issues and the stigma and the social isolation, and that's why we chose this particular scenario. And any other comments from the participants before we ask Shriya? Where do you start this communication? It's not very uncommon to see patients, especially with head and neck cancer, when the wound is visibly seen outside and when there is foul smell, discharge, and maggots. It's not uncommon to
Maggots
see
also
patients
seen.
isolated.
It is very uncommon. Is patient अगर proper caring नहीं कर पाता है तो maggots are also common in this setup. जी मैम.
Shriya, would you like to comment on this? How to go ahead with talking to family or get maximum support?
The first thing Dr. Ishwar had mentioned, there is no psychological facility. Dr. Ishwar, first thing we need to identify if there is any local organization that is providing any kind of counseling support, and also maybe connect them to some sort of a mental health helpline, which could be facilitated by one of the physicians and then taken forward. One of the first things to address for the patient is his relationship with his immediate family. And you can imagine the kind of distress that the patient must be going through when the children don't come to him. So that's the first thing. And then obviously the counseling needs to be done not just for the patients, but also for the family. And when I say it's not
family
just psychological
and counseling.
Yeah. So we just don't need to provide psychological counseling at first go. We first need to psychoeducate them. You need to tell them about this diagnosis, prognosis. When they feel the ulcer is looking, it's making him look like a monster. Like he remembers these words, So we can address first, talk to the children first, talk to the wife first. and then see how that can help. And you as healthcare professionals can do it yourself to begin with, and then psychological counseling can be referred to through other organizations or helplines and stuff. But the first thing we need to address is his relationship with the family, and yeah, so that's something which is very crucial. That's just my point of view.
Yeah, I think there are a few charts, and I totally agree to the fact that once you admit the patient for a few days, remove the foul smell, give proper medications and remove the foul smell, and once you do the dressing, clean dressing, then having sit down and have the conversation with the children, rather than telling them to take care of the patient. Ask them what are their issues, what are that they are facing. Like we deal with in communicating bad news, deal with in collusion, where we initially support, okay, the family members, okay, we are not telling until you give permission, but tell me about your concerns. So likewise, I think someone has mentioned that in chat also, it is important to sit with children and ask about their concerns, so that they will feel that you are not questioning them. Then they will, okay, this person is okay, then they'll start opening up. Meanwhile, you can manage the foul smell and the maggots and the clean wound dressing. And if the children is not willing to give the wound dressing, that is fine. Many of our patients, they do wound dressing on their own. Like we mentioned in the last session, we can teach, they use a mirror in front of them, and then they
Yes.
do the wound dressing. So it's our part to teach him. Sometimes, as you said, from what you said, I understand the family may not be happy to do the wound dressing at all. So once the wound is clean, foul smell is over, the oozing is over, then you teach the patient himself to keep a mirror in front of him and do the daily dressing. So if he is doing the daily dressing and the wound is not foul smelling, generally family accept them much more. When it is okay, not wet and smelly dressing, they will be quite okay. So it's important to have this conversation first with the family, not to push them that it is your duty to take care of him, it is you have to take care of him, but ask them, we understand that you are in a very difficult position, but tell me what is that you are worried about, what is your concern in taking care of him. So it's not easy for a layman to see maggots from a wound, right? It is scary for everyone. Seeing a wound is scary. Having this foul smell, we are all used to it, so we don't feel this as a problem. But for family, that might be very scary and very stigmatizing for the society. So it's important to have this conversation, and very importantly, wound care. Once the wound is clean, I think the family might be able to accept it. And I understand we had a session on wound management day before yesterday.
Right.
uh, yeah, so maybe you can try all those metronidazole and dressing, which will reduce the smell and the maggots, and encourage them to use a mosquito net around the place
Right.
where he's sleeping, so that there is no problem with maggots anymore in the future. I think that's
Thank you,
from
ma'am.
my side.
Thank
Anyone
you.
else want to comment, any add anything?
Kano opposite kino pa amang mo datole. Karino maming kari.
Sorry, we had to rush through your presentation. I was focusing just on the psychosocial part of it, but definitely increasing the morphine and adding some adjuvants. I am slightly confused about the TPN, about how far it is going to help him at this stage of illness. I'm not really sure. But
Because, ma'am, there is no feeding are there. So TPN was given for nutritional support.
okay, I understand. I understand.
जी, जी, जी.
But the role of TPN in the advanced stage of illness is very questionable, and there are
We already have
This is
a lot
only
of
for the nutritional support, ma'am.
we have
Only the TPN is given for. Yes, yes, ma'am. Yes.
yes, that's what it's very quite debatable. During advanced illness, it doesn't have much role in nutrition as well. So I think that we'll be dealing with that when we deal with end of life care sometime. But yeah, that's one thing that is um that we need to discuss about. Dr. Sanjana, someone was talking. You were telling something?
I know I asked whether the patient is already having rice tube. So like nutrition water we can also give to the rice tube. So GPN,
Exactly. Yeah. Yeah.
GPN is also very expensive, even in a government setup.
The TPN is available in our setup. It is the free of cost, so we will give on this.
Free of cost, sir, but that GPN can be used for
Huh.
other patients, right? This
Ah,
patient we can add with,
right,
we
but
can manage with rice to feeding itself.
okay. Thank you. Thank you.
Uh,
Uh,
like one point, ma'am, when we deal with families, usually what the problem we see is many of the patients, uh, they may not, when they were healthy, they may not be having a good relationship with the family. Mostly with the male members, they could be abusive, like they could be already abandoned by the family and now they are sick and the family is forced to take care of them. So how you deal with that, those kind of persons, like when the family, he was not a very supportive person before the illness also, so the family is not wanting to take care of him. That is a tricky problem. We
yeah,
cannot
very,
guilt them
very
into
important
we cannot guilt them
point that
into
you
taking
brought
care
out.
of the patient.
Yes, yes. That we come across very often. Initially, we think that the family members as villains. How can they ignore this patient? And once we start talking to the neighbors and the community and the support system that Shreya was mentioning, then we come to know about the history that he might have abused, he might have been abusive father, never took care of them, was beating them up for a long time, so they don't want to take care of him. That we come across very often. So what our social workers try to do is like have a conversation with the family. Many a times when they see that this person is dying with such an incurable illness, at least like we talk to the sons and daughters and wife, brothers, at least one of them usually comes forward and telling that okay, he had done this in the past, we know that. Sometimes they even keep telling that to the patient also, but still there might be one person who will be willing to support. And there are instances where none of them were okay. His daughter was working in the regional cancer center, still they told to know he has done enough in our life, so whatever happens to him, even if he is dying in front of us, that is fine, we are not going to come and take care of him. And he was in terrible pain and he was having hepatocellular carcinoma. Then we had to depend on the community volunteers, and one person volunteered to take care of him and take him to hospital. He was a rickshaw driver, so we contacted their small association and they were all willing to pool money and rent a house for him and sleep with him for during the night and take care of him. Yeah, so it's again, I think communication is the key. Even though we know that they may not be able to come back and look after the patient, we try to have a conversation with them. We tell them that this is the situation, this is the last few days, there is no point in fighting anymore, right? Anyway, he's not going to live long.
In the end stage, we can
Yeah,
say, ma'am, this is the last stage.
yeah,
But most of the patient, when they become bedridden, they may be
yeah,
needing
yeah.
prolonged care.
Yes,
And
yes,
I
very
mean,
true.
I personally feel this ethically, like I cannot force them when the person is have an abusive past. We cannot ask those victims to take care because it's a very traumatic for them. Also, they don't want to deal with him anymore. And like even the bedridden patient, I have seen many patients who are, even though they are bedridden, they may be verbally very abusive. It's very it's very common and it's very difficult to
Yes.
deal with.
Yeah, it's very true. But then again, we have to go back and think our first duty is towards patient, and then only the family comes. That's the, I mean, I don't know, unfortunate or fortunate fact of it. But when you are having a dilemma whether to support the patient or the family, I think it's always the patient comes to us first and then family. But not supporting a patient to be abusive to the family members, not definitely that. But you don't need to be feeling guilty or shame in asking the family members to take care of this patient because he. So what about patients, prisoners? That's a huge discussion. What about prisoners? Like we had experience of prisoners being referred to us who was a murderer in a very famous case in Kerala, very well known criminal, but he had an oral cancer. He was in terrible pain and he was referred to us. So it was a very difficult task from our side uh, to keep the bias away from us and to treat him like any other patient. So because I have heard some of us will at least pass a comment that he deserved this, but you can't just do that. So we had references from a lot of prisoners, but then again they are patients. We can't be biased because they did something in their past, but whatever they are going through is now is actually suffering. So yeah, and this prisoner was quite abusive even when he was a patient. So that was adding on to our dilemmas, but still our primary interest is to take care of the patient and the suffering. That kept us going for that patient actually. Shriya, any last comment to that?
Yeah, just one of the first things, I think the principle is stop being judged. We cannot be judgmental. Like that's just not possible as healthcare professionals. And like again, sometimes through communications, many solutions are found, whether it's through psychoeducation, counseling, anything. So maybe having one-to-one with the patient itself and getting the family involved, slowly educating them. But again, we may not have solutions to all the problems. And as healthcare professionals, we just need to provide them with utmost care that we can at that point of time. So yeah, that's all. But thank you. It's been an honor to take this class. I sorry, I had no clue there was a case study. I would have like shortened it and just finished it off fast. So I'm sorry about that. But thank you all for coming up with so many great points about what you as professionals have been through the pandemic, and wishing you all just to stay safe, be well, take care of yourselves. That's all I have to say. Thank you again.
Thank you, Shriya. And just one last closing comment. You were mentioning about a lot of problems that you have all faced during the pandemic, and as she was mentioning, it is the life of our patient every single day. They go through this, even if it is a pandemic or not. That's the fact for them every single day for many years. Isolation, unable to talk, death, anticipatory grief, guilt, shame, every single thing. We have learned it through the pandemic. But when the pandemic came and people started talking about all this, we were all wondering, okay, this is what our patients go through every single time. And then we don't talk about it. Yeah, so that is one thing that we can keep in mind. And thank you everyone for the active participation and bringing in a good discussion. Thank you, Shriya, for taking the session. And so sorry that we could not inform you about the case presentation. Thank you, Dr. Ishwar, for your presentation, Sri Priya. And I request everyone to join for the Conquer Cancer documentary screening happening at 5:30. The link has been shared in the WhatsApp group. This is the first time this movie is being screened in India. So please try to join us for the event. Thank you.
Thank you, Shriya ma'am, for joining us and giving us such a wonderful time. Because personally, this session has always been interesting for me, being a non-medical professional, so I understand some bit of it. So, and as usual, your charm has made it more the beautiful, your interactive session. So with that note, this is Sri Priya along with Shriya Singh and Dr. Sridevi Warrior signing off from the Tips Eco Hub. See you in the next session with another interesting topic and another experienced faculty. Till then, stay safe, stay healthy, be happy. Bye-bye.